Assalamu alaikum and good morning, everyone. My name is Amani Abdurrahman. I am an associate professor of pediatrics at Zaim Al-Azhar University. Delighted to give you this lecture today, and I hope it's going to be a beneficial and a fun lecture. So let us get started. Our lecture today is going to be about leukemias in children. Let me start first by objectives of our talk today. It's going to be about definition of leukemias, different types of leukemias, how do we classify leukemia, what are the expected symptoms and signs of someone who is having leukemia, and the treatment, and just few words about the prognosis. The best way is to go through this lecture together by listening to the recording while looking at the slides, because I have the slides open in front of me right now. Let's have a look at the first slide, which you can see it is named or labeled as hematopoietic stem cells. We want to define what is hematopoiesis. It's a process by which all mature blood cells are produced. And this hematopoiesis occurs in the bone marrow. Hematopoietic stem cells give rise to different types of blood cells, namely myeloid and lymphoid. Lymphoid cells include T cells, B cells, and natural killer cells. The myeloid series of the myeloid cells include erythrocytes, megakaryocytes, monocytes, which then become as macrophages, neutrophils, basophils, eosinophils. These last three collectively are named as granulocytes. There is a word that is pluripotent stem cell at the top of the slide. What is pluripotency or what is multipotency? It is the ability to differentiate into all types of functional blood cells. While self-renewal, as you can see on the other side, is the ability to give rise to identical daughter hematopoietic stem cells without differentiation. If there is any mutation during this hematopoiesis or during this hematopoietic development, this will lead to a range of pathologies such as leukemia, myelodysplasia, and bone marrow failure. What is leukemia? The definition of leukemia is a malignant transformation and proliferation of hematopoietic cells. It is generally divided into acute and chronic types. In the acute type, we find clonal expansion of immature precursors, while in the chronic type, the expansion is mainly in the mature bone marrow elements. There are 4 types of leukemias. In children, the acute lymphoblastic leukemia, the acute myeloplastic leukemia, and the chronic myeloid leukemia, which is a less common type associated with a fusion protein, namely BCR-ABL, which activate tyrosine kinase mutation. And the last type is the juvenile myelomonocytic leukemia, which is again rarely seen in children. Leukemias in general is the most common form of childhood cancer. So number 1, childhood cancer is leukemia, followed by brain tumors. The ALL, or the acute lymphoblastic leukemia, accounts for about 75% of the cases, while the AML accounts for about 20% of the cases, and the CLL, which is the chronic lymphoblastic leukemia, is essentially never seen in childhood. The general clinical features of leukemias are similar since all involve severe disruption of bone marrow cells. There is just considerable differences in response to therapy and prognosis. What happens in acute leukemias? The bone marrow precursor cells lose their ability to differentiate to mature cells, and they will stay as blast cells. These blast cells do not function effectively, and they will divide uncontrollably, taking a huge space of bone marrow at the expense of the other types, namely the red blood cells, the platelets, and the normal white cells. This will lead to anemia, thrombocytopenia, and leukopenia, as these white cells are not functioning effectively. Then what happens? These blast cells will spill out to the blood from the bone marrow, and they will settle in the following organs and structures, leading to their enlargement, leading to hepatomegaly, splenomegaly, lymph node enlargement, and thymic enlargement. We will talk about these features when we come to the symptoms and signs. Acute lymphoblastic leukemia is more common in boys than girls. It is associated with some environmental factors and etiology, such as exposure to radiation and as well exposure to chelating agents used in chemotherapy. That is to say, sometimes patients are having some sort of malignancy and they are being offered chemotherapy, and they end as having acute lymphoblastic leukemia as a side effect of the treatment. It is as well has an association with some immunodeficiency syndromes, ataxia-telangiectasia, and some types of chromosomal anomalies such as Down syndrome. This is a photo of a baby or a child who is having Down syndrome. The facial features are very clear. It seems that there is a missing diagram of chromosomal arrangement in cases of Down syndrome, where you can see a triple configuration at chromosome 21 instead of just 2 chromosomes. That is why it is called trisomy 21. And they end as having, instead of 46 chromosomes, they end as having 47 chromosomes. This is a picture of ataxia-telangiectasia, where you can see these telangiectatic vessels very clear in the sclerae. ALL as well can be associated with chromosomal translocation. The commonest type is translocation between chromosome 12 and 21, and this is called the mirror image. And rarely it is associated with translocation of chromosome 9 and 22, and this is called Philadelphia chromosome. Philadelphia chromosome positive ALL is very rare, where it is seen in less than 2% of the cases. These translocation will result in production of abnormal cellular protein, and this will affect in turn the cell function and division. Now we're going to go over the classifications. There are 2 main types of classification. The first one, which is actually an old one, and it is not used commonly nowadays. It is called the FAB classification, which is the French, American, British. In it, we find that it is divided into L1, L2, and L3, depending more on the morphological and the maturation of the cell, where L1 is a small lymphoblast with little cytoplasm, L2 larger cells with more cytoplasm, and L3 large cells with cytoplasmic vacuoles, and in L3 the cells are more mature. These are photos of different stages of the lymphoblast. You can skip them. Then the most commonly one used for classification, which depends on the cell membrane markers classification. As you can see on the left, the B cell lineage, where the cells are or the classification where we can see this is a pre-B-ALL or acute lymphoblastic leukemia, then the pre-B-ALL, then the common ALL, common acute lymphoblastic leukemia, and lastly, the mature B-cell ALL or the so-called Burkitt leukemia. And this is very common. It looks more commonly like the L3 type in the FAB classification. On the right side, we find the T-cell lineage, precursor T-cell ALL, and the mature T-cell ALL. It's very important to know the cell markers as it carries a great role in prognosis and the type of treatment the patient should receive. There are certain immunological markers associated with the T and the B cell leukemias. CD10 is commonly associated with the common ALL type, while CD2, 3, 4, 5, 7, and 8 are associated with T cell lineage. The clinical features of leukemia. There are typical signs of symptoms of acute leukemia, and they usually occur as a result of either bone marrow failure or organ infiltration. If we look at the symptoms of anemia due to the reduction of the production of the RBCs, patients usually present with fatigability, pallor, and shortness of breath due to anemia. As well, they can present with repeated and persistent viral illnesses due to neutropenia, as well as acute flu-like illness with fever and malaise. So they usually come complaining of having a fever and an upper respiratory tract infection that is not resolving for the last 2 to 4 weeks. Symptoms of thrombocytopenia or reduced number of platelets are usually bleeding, which is mainly mucosal bleeding like epistaxis, petechiae, and purpuric rash. This is a picture of purpura and petechiae, and you can see the difference. Petechiae are small and tiny, while the purpura are large, bleeding. As well, the symptoms of organ infiltration are hepatomegaly, splenomegaly, enlarged lymph nodes, skin nodules, gum hypertrophy, and this is seen mainly in acute myeloplastic leukemia in the pro-myelomonocytic type. Central nervous system involvement, and this patient will present with cranial nerve pulses, headache, vomiting, and seizures, and this is due to extramedullary spread. Bone and joints pain as well due to bone infiltration by these blast cells and periosteal bleeding. How do we diagnose leukemia? The first step in the workup for diagnosing leukemia is looking for a complete blood count so as to detect reduction in the RBCs, anemia, reduction in the platelets, and as well the white cells can be reduced or increased. As well, you can look at the peripheral blood picture. Sometimes you can detect blast cells. Presence of blast cell in the peripheral blood picture is very serious, and you should think immediately of leukemia. Bone marrow aspiration or biopsy, looking for the number of blast cells. Usually in the normal bone marrow, the blast cells are up to 1 to 2% of the bone marrow, while in leukemia, they go up these blast cells to 20%. Cytogenetic studies, as mentioned previously, these translocation between the different chromosomes, 21 and 12, the 9 and 22 in Philadelphia chromosome. The immunological markers as the CD10 with the common ALL and the other types of the CDs with other types of leukemia. The immunophenotyping or the flow cytometry. Immunophenotyping is a laboratory technique used to identify proteins that are expressed on the cell surface. The commonly used method is flow cytometry. Immunophenotyping can help differentiate the subtypes of ALL and the stage of maturation of these malignant cells. Expression of the terminal deoxynucleotide transferase, the TDT, on the cell surface indicate malignancy. Doing a chest X-ray looking for mediastinal enlargement, and this is usually with the T cell type, and the patient will present with respiratory distress due to this enlargement and pushing of the mediastinum, possibly on the trachea or the other structures in the chest. As well, doing a lumbar puncture for evidence of blast cells in the CSF. This indicates CNS involvement. But we have to be very cautious in doing a lumbar puncture in patients who are having signs of increased intracranial pressure. As well, doing a renal function test, uric acid, and this workup is very important before the initiation of treatment so as to avoid the so-called tumor lysis syndrome. What about the differential diagnosis? Whenever we have a patient with all these symptoms mentioned previously, a differential diagnosis, it could be aplastic anemia, as these patients as well will present with anemia, with thrombocytopenias features like bleeding, and with evidence of infection. It could be just aplastic anemia. Myelofibrosis as well, we have to think of it. Bone marrow infiltration in the cases of neuroblastoma and retinoblastoma, as well as infectious mononucleosis, which is a viral infection due to EB virus, and the patient will present, as you know, with fever, with pallor, with generalized lymphadenopathy, with splenomegaly, and so it comes in the differential diagnosis. It's very important to know about the poor prognostic features in acute lymphoblastic leukemia, or the so-called the high-risk groups. So male sex are generally considered as high-risk group, and this is due to this testicular involvement where some of these immature or these malignant cells can reside in the testicles and will be a form of relapse later on after the treatment. Age below 1 year and above 10 years is considered as a poor prognostic feature. White cell count of more than 50,000 at the time of presentation. The presence of mediastinal mass is again a poor prognostic feature. Evidence of CNS involvement such as cranial nerve pulses, increase intracranial pressure. Mature B cell type is considered as a poor prognostic feature, and the L3 morphology in the FAB classification. The presence of Philadelphia chromosome is again a poor prognostic feature in acute lymphoblastic leukemia, but as we mentioned before, it occurs in less than 2% of the cases. What are the phases of the treatment? There are mainly 3 phases of treatment. The first one is the induction of treatment. Let me say that treatment regimens, there are different roadmaps and regimens for the treatment of leukemia, depending on the type and the stage of the blast cell. But there are mainly induction of remission for the first 4 to 6 weeks, then the intrathecal treatment with chemotherapy, plus or minus cranial irradiation or testicular irradiation in cases of male, then the treatment is continued for 2.5 to 3 years. The treatment regimen depends on the type and the stage of the blast cell, and it is mainly chemotherapy, radiotherapy, or stem cell transplant, and I'm not going into the details of chemotherapy or these treatment modalities. The prognosis is excellent for acute lymphoblastic leukemia, and there is a cure rate in up to 90% of the patient, especially the low-risk groups. Just few words or few slides about the other type of acute leukemia, which is the acute myelodysplastic leukemia. It accounts for 20% of the cases of leukemia. In it, there is equal sex frequency, unlike the ALL, where there is male predominance. It occurs more in older children, and there is increased frequency of acute myelodysplastic leukemia with chromosomal breakage, like Fanconi anemia, and it can occur as a second tumor after cancer chemotherapy, like the ALL, but it is more common that patients with cancer chemotherapy, they end into AML. In the FAB classification of this type of leukemia, there are 7 stages, but I would like to mention few words about the M3, which is the pro-myelocytic type, which is associated with activation of the clotting process resulting in DIC or disseminated intravascular coagulation. So patients diagnosed with this type are susceptible to bleeding, especially with the start of treatment. Patients who are having more mature cell type, they are likely to do well than those patients who are having a stem cell phenotype. And by this, we come to the end of our lecture on the leukemias, hoping that it was useful and understandable. Thank you so much for your time and attention.